Hi, everybody. I'm Heather Edgar, and I'm here to introduce Dr. Shamsi Berry. I'm delighted to do so, to introduce her as our colloquium speaker for today. I first met Dr. Berry on July 1st, 2003, which was my first day at UNM. By that time, she and a couple of other graduate students had been holding the osteology laboratory together with metaphorical Elmer's glue and masking tape, with no curator, no lab manager or collections manager for over a year. And we have been working together ever since. I'm not going to provide you with the customary information about Dr. Berry's educational research background because she's going to explain that information herself. Due to her unique career trajectory, I've asked Dr. Berry to speak not just about her current research, but also a bit about how she got to where she is today. And I hope this information will help us all think more broadly about the kinds of careers open to scholars with anthropology degrees, given the wide variety of skills students develop on their path to their degrees. So please join me in welcoming Dr. Shamsi Berry to our colloquium series.
Thank you, Heather. So today I'm going to be talking about merging anthropology and informatics. So basically what I do is try to improve health using data from the dead. But I want to talk a little bit about how I got started. And here's a picture of me out on a dig with Heather. And I got my PhD in 2011 from UNM in biological anthropology. And I focused on how to estimate body mass from the skeleton and then use that estimated weight to determine social status within groups from the coast of Georgia. And during that time when I was at UNM, I worked in the Laboratory of Human Osteology, and I focused working on the documented collection for quite a few years, as well as the prehistoric and historic collection there. And then towards the last couple of years I was there, I worked on the 𝗏𝗏𝗏𝗏 collection, which is a collection of about 6,000 orthodontic records that include casts of teeth, intraoral photographs, and treatment information. And part of what I was tasked to do with that was to look at all of these cephalometric measurements, which are measurements taken on the lateral x-ray that's used in orthodontia, to use those cephalometrics, and they had been taken from all these different standards throughout time. He had sort of collected, oh, I like this standard over here, and I like this standard over here. And I was sort of tasked with creating this unified standard because a lot of the measurements were the same in some of the standards, or they would have the same name, but actually be different measurements. So from that, I actually created 88 new standardized terms that we entered into a system called LOINC, which is logical observations, identifiers, numbers, and I'm blanking on what the C is right now. But that was what introduced me to data standards and informatics, and I really liked it. So I wound up applying for and getting a postdoctoral fellowship at UNM under Phil Croft in the Health Sciences Library and Informatics Center. And in that postdoctoral fellowship, it was a research fellowship for 3 years. I earned another master's degree in biomedical sciences. I got a graduate certificate in biomedical informatics from Oregon Health and Science University. And I also got a graduate certificate in clinical and translational science from UNM. And while I was there, I started on the research that I'm going to be talking about, and I performed basically research on minimum data sets that had to do with medical examiner data. But I'll get into the details of that in a minute. But I do want to comment on one thing, which is at the last institution I was at, I was primarily teaching based. And I have to say, and it was in informatics, the vast majority of stuff I taught, I actually learned in my PhD in anthropology, not from my postdoctoral fellowship in informatics. I just wanted to mention that because we have such a broad background of information that we get. So I do want to give a warning that there are human remain images in this PowerPoint presentation. So I'm going to give you some background about the research I did as a postdoctoral fellow, as well as current research that I've been doing. So the Office of the Medical Investigator, or OMI, in New Mexico is a statewide centralized medical examiner's office for the whole state of New Mexico. So any death that occurs not under the care of a physician is going to be routed to the OMI. And in 2010, they got a new facility, and it also came with a CT machine and an MRI machine. And the ethnic and racial diversity at the OMI is pretty much similar to the New Mexico census from 2010, with about 10% American Indian and 35% Hispanic. So in 2010, the OMI received a National Institute of Justice grant to test whether or not CT images could actually be used to supplement or supplant the traditional autopsy. And they were focusing on three things: gunshot wounds, sharp force trauma, and shaken babies. But in order to make sure that people weren't only looking at those three things, the images, CT scans of those three things, and saying, oh, well, it's got to be one of these three because otherwise they wouldn't have CT scanned them, they had to CT scan every single individual that came through. So that resulted in about, I think, around 3,000 to 5,000 scans by the end of the grant. So, and they continued to scan after the grant was over. So by about 2010, that resulted in about 15,000 CT images, but they had no plans for the reuse of these images. They didn't really know what they were going to do with them. And the OMI database was separate from the images and the information that was contained on the images. So on the images, they had some information such as name, their OMI number, which is a random number that they're assigned when they come into the OMI, and very little information. There's a few other fields, but not very much. And then separately, you have the OMI database, and that is primarily made up of free text fields. There's very few standards that are built into the OMI database. There's some exceptions, and I'll talk about that a little bit later. But basically, you can't search an image and say, I want to find all the individuals that had diabetes. So you can't search the image and pull that information out, but you can search the metadata. So for my postdoctoral fellowship research and my second master's degree thesis, I actually helped determine what the data set should be to associate with these CT images. So I used a modified Delphi method, and I queried 42 experts from multiple domains. I didn't want this just to be useful to anthropologists or informaticians. I wanted it to be useful to the widest variety of researchers possible, because this is such a unique data set and so many researchers could use it. So here were experts' self-identified research domains, but a lot of experts, this was just their first research domain. A lot of experts actually fit into multiple categories, but I made them choose one for their first domain. From that research, I was able to determine a minimum data set of 59 variables. And it really broke out very easily. It was either have 5 variables, have 59 variables, or have over 100. So 59 seemed like a really good number that we could work with. So this is the list of the original 59 variables that we came up with. Now, Heather Edgar and I also had some additional variables we wanted to add to the database for Heather's research, and also some additional feedback I had gotten from the second half of my research, where I tested whether or not the variables we selected were useful. So I added in marital status, and then Heather added in some additional variables that she was interested in. In the end, some of those variables, such as former alcohol use and current alcohol use, wound up having to be combined because of the data standards that I found for them, and others had to be separated. For example, sex and gender was selected as a combined field in the original 59, but of course those are two separate concepts, so they had to be separated. So some actually got separated, some got combined, but in the end we wound up with 3 sections: census, health, and circumstances of death. And these are the variables that are in the database. So in 2016, Heather received a grant from the National Institute of Justice to actually create the database. And I was the biomedical informatics consultant on the project. And I was tasked with creating the data and vocabulary standards and cleaning the data and then importing some of the data. And the data is coming from 2 sources: the OMI database, which needed a lot of cleaning, and standardization, because remember I told you it's vast majority of the fields are free text. And then we also got information from the next of kin. So I also helped with determining the how the database structure was and the website interface, which provides the metadata and the CT scans to the researchers. I do want to mention that we developed a research protocol for UNM IRB. The IRB did determine that the next of kin were not the subjects of the research, and therefore there was no human subjects research approval needed. However, we still followed that protocol. We still were compliant with HIPAA. So we have zip code as one of the fields, but in order to be compliant with HIPAA, it's only the first 3 digits. We don't have name included. Instead of birth date, it's birth year in order to be compliant with HIPAA. So we did still follow the research protocol. So right now, I'm going to talk a little bit about my creation of data standards. So there is something called the Unified Medical Language System, and UMLS, and it's basically terminology services. And it has something called a meta thesaurus. And basically you can put in a term, and in this example here, you can see I put in smoking status as the term, and it searches all different data standards that are out there and helps you determine, okay, smoking status has an NCI data standard, it has a LOINC data standard. So you can see all the different data standards that are out there. So what I did was I took that list of variables that we were having in the database, and I created a list of standards that were used and listed in the meta thesaurus. And then I searched each one of those standards to see how it was written, the different options for basically the drop-down menu of what you'd be selecting for each one of those variables. And then I also searched LOINC and SNOMED CT, even if they weren't listed, because those are 2 very common data standards in the medical record, and they have a lot of different standards in them. So even if it wasn't listed in there, I did search those just to make sure. And then I determined the normative answer list. And basically that's that drop-down menu that you can select the different variables from. So for smoking status, it would be, you know, like heavy smoker, light smoker. Those aren't actually the standard options, but I can't remember the exact words of it. So basically then I had this whole list of different data standards, and I said, what is going to work for this database with this population? And then I would either select to use the standard as is, modify the standard, or create a new standard. So I'm going to talk about one of the examples of this, which was actually one of the more complicated examples, and that was diagnoses. So medical diagnoses, it didn't include any cancer diagnosis or congenital abnormalities. Those were collected separately. So there were some options here. I could use SNOMED CT, which has over 100,000 codes for diagnoses and is extremely specific. Or I could use ICD-10 codes, which are used for billing, and these have over 70,000 codes, but it's 7 characters long. So characters 1 through 3 give you the category of the disease, 4 gives you the etiology of the disease, 5, the body part affected, 6, the severity, and 7 is a placeholder for any kind of extension code. So with ICD-10, I could just use the first 3 characters, and this would get it down to 2,040 diagnoses. But there's 2 things. One, are we going to see all 2,000 diagnoses in this population? There are some categories that we're not really going to see in modern day New Mexico, such as yaws and pinta. We're not going to be seeing that in the population. So do we really have to have that as an option? Additionally, things such as malaria are broken down into the specifics of it. And our next of kin going to really know the details. They're probably just going to be able to tell you somebody had malaria, not necessarily what type of malaria. So my options became using the SNOMED CT codes. Remember, that's over 100,000 codes. And we have to go through this when we call next of kin and determine which diagnoses they had. We could use the ICD-10 full codes, which was about 70,000. We could use the ICD-10 category codes, which gets it down to 2,000. We could modify an existing code, or we could create a new standard. So as far as modifying an existing code, there were just still way too many options. We would have to go through and group things together, break things apart. So it seemed like the easiest thing to do would be to create a new code. So we were trying to capture the most common diseases that we see in this population and at the level that next of kin would recognize. So in the end, we wound up creating a new standard, and we sought to capture the 20 most common disorders that we would see in this specific population. Now, as I said before, congenital abnormalities, chromosomal abnormalities, and cancers were collected separately, so we didn't have to worry about those diagnoses. So in the end, we wound up with 20, and if you counted here, you'd see more than 20, and that's because as we went through this, the people actually doing the calls said, hey, we're actually seeing a lot of individuals that have this disorder and it's not on the list. So we added it into the database because we collect the information of additional diagnoses that are not on this list. So in the end, we can go back and say, you know, actually 1,000 people had this diagnosis. We should add this into the database. So when we were creating these data standards, it really became a balance of these multiple forces. So you want to use standards that are used commonly, but you want to think about the specifics of this population. You want to think about where you're getting the information. So you have to think about the knowledge level of the next of kin. Most aren't going to be medical doctors and have very specific information about the diagnosis or any of these variables we're asking about. You also need to think about the level of information that's given in the medical examiner's case. All of that information is collected to work on the medical examiner's case to determine manner and cause of death. It's not necessarily to give you all of the information about the background of that individual. So you also had to think about the ease of entering it into the database. You couldn't make it too complex. If there was a dropdown with 2,000 diagnoses that the people entering data into the database when they're calling next of kin had to go through, that would be really difficult. And then we had to think about researchers' interests. What were people going to be studying and what would they be interested in finding in this database? So in the end, 26% of the fields mapped directly to existing standards. This included smoking status, sex, gender, marital status, as well as a bunch of others. 7% required some kind of modification, such as birthplace. We added in born in Mexico as one of the options. And then drug usage. So drug usage, we used a standard, but added in former drug usage as an option as well. And then 66% required some kind of new standard. So for something like alcohol consumption, there are standards that are used, or there are classifications that are used in practice to figure out if someone is high risk or low risk And those we used and modified in order to create the new standard. Other things we couldn't find standards on, such as dental health. There were some partial information in SNOMED CT on dental health, but not complete. Other things that I did was actually use natural language processing, which basically helps extract data out of free text blocks. So I used a program that was created at Harvard that is freely available called Canary. And I used that to extract things such as medications. And here's an example of someone's free text field for medications. And I wanted to pull out all of the medications that were taken. I also am currently working on conditions of the body where they exposed outdoors, where they found indoors, where they burned, where they underwater, etc. I also used it to determine the tribe for the American Indians in the population. I used it to determine marital status, and I am going to use it for gathering additional information on alcohol use and drug use for the individuals that we weren't able to contact their next of kin. So in the end, we've created the New Mexico Decedent Image Database. It went live in February of this year. And you can find it at nimdid.unm.edu. We have now more than 280 users, more than 75 image requests. I created this about 2.5 weeks ago, and we had 36 countries represented. So it's really an international use. Now I'm going to talk a little bit about my current and future research. The main thing I'm doing is I want to work with additional medical examiners' offices to add in some ethnic and racial diversity that's not present in NIMDID. So there's not a huge percentage of African Americans or Asian Americans because the state of New Mexico doesn't have a large proportion of those individuals. So I want to work with medical examiners' offices to actually add more additional data into the New Mexico Decedent Image Database. And the key there is I have to work with places that have a CT scanner so that we can have the CT images. I also want to work to improve the interface. So there's some things that I'm not 100% satisfied with and would like to continue to work on and make it even easier for researchers. And then in addition, some of those standards I used that were OMI standards, such as cause of death and manner of death. Those are specific to the Office of Medical Investigator in New Mexico. Not every medical examiner's office uses those. They created them themselves. So I have to create a crosswalk between the new medical examiner cause and manner of death and the OMI, which is what we use in this case. Then I actually want to use this database. And there's two things I'm going to be talking about today that I am currently using the database for, and I'm just about to start using the database for. And that's looking at Hispanic data standards and the Hispanic paradox, and trying to create a better algorithm to capture overall health by looking at fat distribution and exploring the obesity paradox. So race and ethnicity are really common data elements that are used in the census, healthcare, vast amounts of research, and in education. But how race and ethnicity are classified really differ depending on what standard you're using. So for the Office of Management and Budget, they have basically used Hispanic or Latino or not Hispanic or Latino. It's just one or the other. Health and Human Services has suggested Cuban, Mexican and Mexican American, Puerto Rico, and another Hispanic group. For the 2010 census, they used Mexican, Mexican American, and Chicano, Puerto Rican, Cuban, and another Hispanic, Latino, or Spanish origin. And the National Academy of Medicine, formerly known as the Institute of Medicine, their 2009 report suggests using 36 different subgroups for the term Hispanic. So really, understanding the variation among these subgroups might be useful in unraveling this Hispanic paradox, in which in the US, Hispanics have better health outcomes than non-Hispanic whites despite a lower socioeconomic standing. So we used a list of 7 subgroups within the New Mexico Hispanic population that were determined by Heather Edgar and Keith Hunley. Use Chicano, Hispanic, Latino, Mexican, Mexican American, Nuevo Mexicano, and Spanish. So unlike the OMB standards, these categories are specific to the culture and history of New Mexico. And they also, for the most part, match the national, what was the Institute of Medicine categories, with the addition of Nuevo Mexicano, which is specific to New Mexico, and the term Hispanic. And that's as a subcategory, not as the main ethnic category. So this was collected on all individuals where we were able to get a hold of the next of kin, and they identified that they were of Hispanic ethnicity or race. In the database, you can choose to have Hispanic as a race, since such a vast majority of individuals in the 2010 census listed it as a race. So I queried the database for all decedents with a Hispanic subgroup, and there were 639 decedents that had Hispanic subgroup information, and this comprised about 13% of the Hispanics in the database. So I determined the mean age at death in years and compared it among the subgroups using an ANOVA. I ran a post hoc Tukey analysis to determine which groups were significantly different from each other, if there was a significant difference. And then each decedent had also been assigned a category manner of death: accident, homicide, natural, suicide, or unknown. And they also had one of the specific manner of death codes. And for this group, it wound up being a list of 60 different manner of death codes were used, such as pneumonia or automobile accident, and those were determined by the forensic pathologist. So I performed a Monte Carlo simulation of the Fisher's exact test with 100,000 iterations. And the reason I had to use a simulation is because it was such a large table with so many of them having 0 counts in the cell that you can't just run a normal Fisher's exact test. You had to actually do a Monte Carlo simulation of it. So in the end, this is looking at mean age in years. We found a significant difference between the Spanish age at death and Mexican Americans, and Spanish and Hispanic. So there was a significant difference between those groups for age at death, with the Spanish dying about 7 to 8 years later than the other groups. So when the 7 subgroups were compared to non-Hispanic whites, there were significant differences found between non-Hispanic whites and Hispanic, non-Hispanic whites and Latino, between non-Hispanic whites and Mexicans and Mexican Americans. The only ones that didn't differ significantly from non-Hispanic whites were Chicano, Nuevo Mexicano, and Spanish. Now, when we looked at if there was a significant relationship between the subgroup and manner of death, we didn't actually find anything when we're looking at just the grouping of manner of death. So this was accident, homicide, natural, suicide, undetermined. However, here's an example of the manner of death counts for Spanish. We did see fewer homicides among the Spanish than expected statistically, and we saw fewer suicides among Chicanos than expected statistically. And those were 2 of the examples of some of the biggest differences that we saw, but it was not significant. Now, when we looked at the specific cause of death code, manner of death code, and the subgroup, it was significant. So that's that list of 60 different manner of death codes. And we see that more Chicanos died of drug use than expected statistically. More Spanish and fewer Mexicans died of prescription pill overdose than expected. More Spanish died of exposure than expected, and fewer Spanish died of gunshot wounds than expected. So these results really make it clear that the Office of Management and Budget, the OMB, and HHS terminology standards are not specific nor culturally relevant enough for research into health and mortality statistics, at least among the Hispanics in New Mexico. The National Academy of Medicine standard, although it's not really wildly used because there's 36 different options for Hispanic in the subgroupings, really is a terminology standard that has more specific regional variation, although we did add in 2 different options. So if we had just used the OMB or HHS standards, we might not have seen what we actually wound up seeing and miss the heterogeneity that's important for understanding public health. So these results indicate that researchers should strive to capture more regionally relevant ethnic data on subjects, or they're actually going to be missing some of the information that's present. The results also, interestingly, argue against the Hispanic paradox, as groups that had more recent migration histories, such as Mexicans and Mexican Americans, die at younger ages than those with a long history in the United States, such as Spanish and Nuevo Mexico. So that's different than what you'd expect to see with the Hispanic paradox. So if subgroups are used when studying Hispanic health, it may elucidate different outcomes that has been captured with a panthetic term such as Hispanic, which could even, in the result, clarify this paradox that people have seen in the past. Now I want to talk to you a little bit about research that I am just starting to work on. I should find out today if I got a grant, an internal grant, to actually start the pilot project for this research. So as probably all of you are aware, obesity is a major problem in the Western world. The general prevalence of obesity has risen 61% since 1991, and 39.6% of Americans are obese. Obesity rates are even higher in underserved and minority populations, with 46.8% of African Americans being obese, 47% of Hispanic and Latinos, compared to 37.9% of non-Hispanic whites. In the New Mexico population, which this is using the New Mexico decedent image database as well. So 28.4% of the population is obese, with 27.6% of African Americans, 39.2% of Native Americans, and 32.8% of Hispanics are classifying as obese. So obesity is defined as an excess of body fat, and it's usually measured in most cases. I know everybody has been to the doctor's office and they've taken your height and your weight and they're determining your BMI. But that BMI doesn't actually measure body fat directly. It's used as a proxy for health risk. So BMI measures the mass of the body using height and weight. There are measurements that do actually get at body fat percentages, and that can be something like underwater weighing or dual X-ray DEXA scans. So those methods are more reliable, but they're difficult and costly to obtain. And research has shown that BMI is not necessarily a good proxy because it doesn't distinguish between fat and lean muscle mass. So if you're a bodybuilder and you have a lot of lean muscle mass, you're most likely going to classify as obese, but you're not going to have any of those health issues that are associated with obesity, such as diabetes, etc. And there's also been a lot of research focusing on the obesity paradox. And it's hitting me that I do a lot of research about paradoxes. So the obesity paradox basically says that those that are overweight or obese actually have live longer lives than those that are normal weight or underweight. So this paradox, however, might be an effect of the BMI categories, not accounting for actual fat mass or percentage, and not necessarily the fact that there is this paradox existing. So I'm seeking to create a new algorithm to study health risks from adipose tissue. And that's the first step in actually evaluating the obesity paradox further. So one way to evaluate the fat mass more directly is looking at the visceral versus subcutaneous fat distributions in CT images. So that's really going to bypass using BMI as a proxy, but it does require a CT scan, which thankfully the New Mexico Decedent Image Database has. Currently, there are no algorithms that can be used to determine overall health risk from levels of adipose tissue distribution, sex, age, skeletal measures, ethnic, and racial data. We have seen differences and areas where BMI has failed using all of those things, such as ethnic and racial data, adipose tissue distribution, sex, age, and body shape, body size. So having a large frame versus a small frame. So using the New Mexico Decedent Image Database, I'm seeking to determine an algorithm to reflect adiposity better than BMI. So this project is going to proceed by determining the fat distribution in CT scans, dividing it into visceral and subcutaneous, and quantifying that amount. I'm also going to seek to determine if any skeletal measurements are highly correlated with fat distribution. If not, I'm going to be using those skeletal measurements to help give a better picture of frame size. And then using multiple logistic regression, I'm going to determine an indicator of overall health and health risk, using fat distributions, age, sex, race, ethnicity, and skeletal measurements. So thank you for your time, and I'm here for any questions.
Thank you very much, Shamsi. So I think, yeah, I would welcome anybody to ask questions. In the last couple of weeks, as you, those of you who've been here know, what we've been doing is just asking people to turn on their cameras and ask the question themselves, and that's been working really well. So does anybody have any questions?
Hi, Shamsi. I was wondering with the Hispanic paradox, I was wondering if some of those differences may also correlate with something like socioeconomic status, where certain groups who identify as as Spanish tend to be of a higher economic background, or if that was sort of even, which allowed those differences to really come through between different ethnic differentiations amongst Hispanic, Chicano, and Latinx folks.
So I haven't looked at that yet, but all of those individuals that have the Hispanic subgrouping we did speak to the next of kin. And one of the questions we asked was about their socioeconomic status as an adult, but also their socioeconomic status as a child. So we could look at both of those and see.
Well, I'll ask a question. First of all, I want to thank you for all of the work that you put into with others generating this database. It is one of a kind, and something that is has just sort of a degree of potential that is actually hard for me to wrap my head around. There's so many possible projects that could come out of this. I have a couple of undergrads working on projects right now, and it's sort of the perfect thing to be doing during COVID times, working with CT scans. But yeah, no, it is really, really fantastic. So thank you for that. One question that I had is whether or not there's been any discussion about making researchers give their data that they collect from the CT scans to the database, so that can be included in the database, so people don't have to constantly be remeasuring the same things.
We haven't talked about people doing that, primarily in the fact that we'd probably have to get some kind of grant to add that much data back in and create those fields. But we do ask for people to share with us their publications that result from their research. So theoretically, you could look at the list of publications and say, oh, this person did the research that I'm doing and probably took the same measurements, and you could contact that researcher and get that information from them. but I am hoping that at some point somebody does some kind of bone density analysis on the images, and that I would ask very nicely to have that data, because that is one of the fields in our database, but we don't have that information.
Great. Anybody else have any other questions?
Yeah, I've got a question. This is Ozzy. There was actually, I was kind of surprised by the kind of leanness of the New Mexico population. I might have thought it would be heavier based on socioeconomic trends in the state. Do you have any idea if that's influenced by age very strongly, or is that it seemed to be independent of age?
I'm not really sure about that population. You're talking about New Mexico as a whole, not this sample, correct?
No.
Or are you talking about this sample?
This sample.
Oh, let's see, I don't actually know what percentage of this sample is obese. I only know what percentage of New Mexico as a whole is obese. I haven't delved into that yet, but I will be, because I will have to determine who's obese to look at their CT scans.
Yeah, it's kind of an interesting, I mean, it's kind of like the osteological paradox in a way, because at the OMI, you see people who are dead, and dead in specific circumstances, so not a physician attending or a homicide or something like that. And so it may be kind of a weird, skewed version of a living population.
It is skewed from a living population, so it's much younger than the living population, than the vast majority of deaths in the state of New Mexico. This tends to be the younger individuals. But it's not, I mean, the vast majority of cases, over 50%, are either natural deaths or accidents. So it's not as biased to homicides and suicides as you naturally are inclined to think when you first think of the database. It's still biased, I admit it, it's biased, but I like to think that it's not as biased as you originally think when you think of a medical examiner's database.
Ben, did you have a question?
Yes, thank you. I actually had two. One was, sorry, I should say, I come from an evolutionary biology background. I'm not in anthropology. Is there a way to work with actual hospitals and other spaces where there is natural death under physician attending to get CT scans to supplement this data? Kind of, if there was a CT scan done kind of in the days or so before death associated with some condition. Is that possible?
So, I mean, yes, it's possible, but it gets really tricky with HIPAA. And HIPAA applies for 50 years after death. So although in New Mexico, the information is considered public knowledge, it still gets tricky with HIPAA and when things were captured when they were alive.
Awesome.
So it is possible. It would require a lot of work and it would be difficult. There are data sets out there that do use living CT images. So those do exist, but they're usually of like one organ. So, and it'll be like 500 of one organ, and there's not a lot of metadata associated with them. So they're not really as useful.
Mm-hmm. Awesome, thank you. And then secondly, so this, you said, is very fortunate because the Office of the Medical Examiner has or investigator has the CT scanner. Are there other states or populations that you know have a similar access that you think could kind of take the exact framework that you took here, take that and then expand this to be a New Mexico plus other states?
Right, yes, and I'm currently in talks with other offices. So I'm in talks with the Los Angeles Medical Examiner's Office. They have a CT scanner and they have a higher percentage of African Americans in their population than they have in New Mexico. I'm also in talks with the the Baltimore Medical Examiner's Office, and I've just reached out to the Georgia Medical Examiner's Office, which I think looks at 153 of the 156 counties in Georgia. They are getting a CT scanner at the end of December. So yes, there are, and there's even more. There's other, I think Oklahoma, there's a medical examiner's office there that has it. The reason New Mexico is the perfect place to start this is it's one of the very few state-wide medical examiner's offices that has a CT scanner. So like I'm talking about Los Angeles, it's not the whole state of California. That would be really hard to do. And then like Baltimore, so they're usually county or city-based, depending on or regional based. So New Mexico was unique in the fact that it was statewide medical examiner's office, but Georgia comes pretty darn close with 153 of the 156.
Yeah, awesome. And do you envision then that would be a singular database?
I do envision it going into a singular database. I mean, they will have to get over the fact that it's called the New Mexico Decedent Image Database. So they'll have to accept that. But I do see, and I did leave it as an option for one of the fields is CT protocol. So I envision that every place is going to have a different CT protocol. So that's one thing you could search for in the future. If you, let's say, just wanted somebody from Los Angeles, you could look for individuals that had the Los Angeles protocol.
Awesome. It's great that you're so forward thinking on this.
Well, thank you. I have been basically working on this since 2011 when I started my postdoc, and I'm just so excited about the fact that it's live and that people are using it, and that I get to use it for my own research. So I'm really excited.
Any other questions? So I had one more question, if you don't mind me asking, and it sort of relates to this process of contacting the next of kin. So really, any individual that has data, lifestyle data or whatever associated with the CT scan, that person was their next of kin was contacted and provided that information.
It depends. So it depends on the field. So something such as Hispanic subgrouping, all of those individuals had next of kin contacted. If it's something like drug use or alcohol use, that could be listed in the medical examiner's database. And if they weren't able to get a hold of the next of kin, or actually even if they did get a hold of the next of kin, they read through the medical examiner's report and pulled all the relevant information out. So it really depends. If the report somewhere mentions that they were, an avid runner or something, that could get pulled out and put into the database without talking to next of kin.
I see.
So, and we have a data dictionary, which talks about all the data standards that were used. And in there, it says the source of the information as well, such as did this come from next of kin, the medical examiner's database, or both.
Right. But in every case, there's each one of these people has a next of kin that's aware that this person is in the database?
Well, the ones that we contacted are definitely aware of it.
Mm-hmm.
We have had, we do have on there in the protocol that if somebody contacts us and says, my next of kin, it must be in this database and I don't want them in there, we will remove them. But we had very few next of kin that wanted the decedent removed.
But yeah, there's definitely a lot of people in the database. So yeah. Yeah. So anybody else have any other questions? It really will be exciting to see just all the different projects that come out of this and all that we learn. It does seem like the projects that you're working on, looking at visceral versus subcutaneous fat and how that might affect various health outcomes, seems like an ideal database to be using for that. So good luck.
It is, and it's basically, I've had this project in mind since we started planning the database. So I built it to make sure that it could do this. So I'm very excited about finally getting in to do it. And I want to do a shameful plug that we are currently in the process of giving webinars. And Heather, you're going to have to remind me again exactly. It's FTCOE?
Yeah, it's the Forensic Technology Center of Excellence, and they sponsored us to do a series of 4 webinars on how to use NMDID. I did the first one this week, but it's available recorded. Shamsi's doing the second one next week. And then 𝗦𝗲𝗿𝗶𝗶𝘀 from the Center for Forensic Imaging is going to talk about how to use 2D images, and then Rachel Menegas from the University of Texas Health Sciences, North Texas Health Sciences Center is going to talk about how to do 3D images. So we're really lucky that they gave us the time and money to provide those webinars.
So if you want to learn even more about NMDID, you can look at those webinars as well. And I'm planning on attending them so that I can learn some more stuff too, especially Natalie and Rachel's. I've only started using the CT scans, so I'm excited to learn more myself.
Excellent. All right, are there any other questions? All right, well, join me in thanking Shamsi for a really enlightening talk. And again, thank you for all the work that you put into creating this database that will be a really important resource for UNM and more broadly. So.
Well, thanks for having me. This was great.
All right, everybody. Same time, same place next week.
Bye.
Bye.